He is going to give us a presentation on the central pathology role for optimizing neoadjuvant therapy. Please, Dr. Vayal.
It's the next session, session 4. Session 4 is on the laptop over there. Okay. Well, my internal biological clock tells me, just go have dinner now, not to talk. So we are waiting for the slides of session 4, and if I remember correctly, the title would be "The Role of Pathologists in the Design of the Neoadjuvant Treatment." And my first slide should introduce my presentation, saying that pathologists have a number of roles in this setting, in the neoadjuvant settings, which is, of course, number one, to provide information in order to select the most appropriate neoadjuvant treatment for the patients, then to have the opportunity of predicting the likelihood of the tumor response to the chosen therapy, and the final role, which is not less important, is that we as pathologists, we have to be effective in collaborating with the rest of the multidisciplinary team in breast cancer to figure out new strategies, new therapeutic strategies for breast cancer patients, especially for tailoring neoadjuvant treatment according to different biological properties of the primary tumors. Yeah. I finished my introduction, so I desperately need the slides now. Yeah. Okay, I tell something that I don't know whether it is a joke or it is true, but you know that Mr. Obama, the President of the United States, sometimes he goes out for dinner with his wife. And so they went to a nice little restaurant in the Washington area. Afterwards, at the end of the session, So they went to the restaurant, and the owner of the restaurant was pushing on the Secret Service people because he wanted to say hello to the First Lady. And so after insisting, the chief of the Secret Service went to the president saying, "Listen, this guy, he wants to say hello to your wife. What should we do?" "Okay, let it come." And so he came and was saying hello to the First Lady, and they had a short chat together, and then he went away. And so the president asked the First Lady, "Oh, but it's strange. Do you know this man?" "Oh, yes. When we were young, we spent some time together. It was so funny." And Mr. Obama says, "Oh, in a different world, now you will be the owner of this beautiful small restaurant." And she replied, "Well, in a different world, now he would be the President of the United States of America." So these are the central roles: inform the choice of the systemic treatment, predict the likelihood of response, and implement molecular screening for the conduct of neoadjuvant trials with new compounds. Let's start with the possibility of informing the choice of the systemic treatment. You know that according to the recommendations of international committees, these are the recommendations of the St. Gallen Consensus, according to the specific biological features of the tumor, we could inform the treatment by selecting the appropriate endocrine or chemoendocrine or chemotherapeutic regimen plus minus specific targeted treatment. it looks easy, but it may be difficult. Because remember that we have to deal with small, in most of the cases, with small core biopsies of the primary tumor. And sometimes it may be very difficult for us as pathologists even to differentiate between DCIS and invasive carcinoma. Another issue is the reliability of the assessment of those biological parameters, ER, PR, Ki67, and HER2, which are informing the choice of the systemic treatment. Especially for HER2, we all know that due to the crushing artifacts of the needle within the tumor, for the removal of the core biopsy, these crushing artifacts may lead to a high number of false positive results in HER2 assessment. So the information to the clinician will be wrong, and the patient will be maybe treated with a regimen including trastuzumab or other anti-HER2 treatments, despite having a HER2 negative disease. And then there will be discordance in case of incomplete response to the treatment when we will double-check HER2 status on the surgical specimen after neoadjuvant treatment. We will then have a discordant result. Oh, come on, it was HER2 positive, the core biopsy. What happened now? Finally, even for Ki67, we have troubles. And I will show you why. Please remember, there is almost always a gradient in Ki67 immunolabeling from the periphery of the tumor towards the center of the tumor. You know, in the center of the tumor there are hypoxic conditions, there is ischemia, and the mitotic rate and the expression of Ki67 in the central portion of the tumor may be much lower as compared to the periphery of the tumor, where the tumor is actively growing. Also, grading tumor in core biopsies is not that easy, because we are losing one of the three parameters upon which we base the histological grading. The first parameter for grading is the prevalence of tubular structures in the tumor. So tubule formation. And of course, if it is more or less than 70% of the tumor forming tubules, it is grade 1, etc. But now we have not the entire tumor, we have a tiny core biopsy. And it's almost impossible to figure out from the core biopsy what is the actual percent of tubule formation. So we are not using to grade core biopsies according to the traditional histopathological grading system, but we will use either a pure nuclear grading system or a cytological grading system, or the combination of the two, but not the classic histopathological grading system. And finally, one other task which may be difficult is to assess the cellularity of the tumor in the core biopsy in order to be able to compare the cellularity pre-treatment with the cellularity of the residual tumor post-treatment, as it is requested, for instance, by the Miller-Payne system for assessing tumor response after neoadjuvant chemotherapy. So these are the issues that we have to deal with in the neoadjuvant setting. Here is an example, if you can see it, of the gradient of Ki67 labeling index from the periphery of the tumor. Maybe there is an arrow here somewhere. Yes, no, maybe, no. Well, you see the periphery of the tumor and the intense immunolabeling at the periphery of the tumor as opposed to the weak or absent immunolabeling for Ki67 in the center of the tumor. Why is this relevant to the discussion? Well, this is because in several cases we tried to get core biopsies right in the middle of the tumor. So the Ki67 immunolabeling of these core biopsies in the middle of the tumor will most likely depict the status of the central region with low Ki67 immunolabeling. So Ki67 in core biopsy may not be truly representative of the mitotic activity, the proliferative activity of the tumor itself. The second aim or scope or goal of pathology in the neoadjuvant setting would be to allow prediction of the likelihood of pathological complete response according to the biological features of the tumor and the therapeutic intervention. There are several parameters that may correlate with the likelihood of pathological complete response, including nuclear grade, tumor type, histologic type, ductal versus lobular, ER and PR content, Ki67 with the reservations that I was mentioning, HER2 status, and gene expression profiles or molecular classification of breast cancer. All these parameters do correlate with the likelihood of response. And the first of them, which is known since many years, is hormone receptor status of the tumor. Because we know that hormone receptor negative breast cancer is much more likely to achieve pathological complete response as compared to the hormone receptor positive breast cancer. But grading, histological grading in multivariate analysis is adding information to the ER and PR status, because as you see in this table, grade 3 tumor will have more likelihood of pathological complete response than grade 1 or grade 2. And combining grade and hormone receptor status will improve our capability of predicting PCR. To the point that we tried to figure out in a multivariable analysis how many and which parameters, clinical pathological parameters, would enable us to predict pathological complete response. Here you see a list of those clinical and pathological variables, and in the column at your right, you see that in multivariable analysis, the final model will include ER and PR expression as predictor of response, Ki67 despite everything, and the number of courses of chemotherapy. These 4 parameters together, they provide additional information, and we can figure out a kind of nomogram. We did it. We designed a nomogram based on the expression of Ki67, steroid hormone receptor status, and number of chemotherapy courses to predict pathological complete remission. And you see that putting together this data, we can predict the likelihood of response in the last scale from 0 to 50% of probability of complete pathological response. Is the molecular classification of breast cancer adding important information? Well, if you take the molecular classification of breast cancer per se, without any other clinical or pathological information, you see that according to the distribution in luminal A, luminal B, HER2, and basal-like, there is a different likelihood of complete pathological response, with HER2-positive breast cancer and basal-like breast cancers being more susceptible to complete pathological response after neoadjuvant chemotherapy. But I want to shift to the last role for pathology that I think it will become more and more important in the next future, and especially in the clinical research setting. As you know, we are all of us, we are aiming at personalizing cancer medicine in all the cancer fields, including breast cancer, of course. In breast cancer, personalizing cancer medicine to me implies that we have to move from the assessment of one or a few targets to the understanding of the entire genome complexity of breast cancer. We should be ready to improve our ability of doing a kind of molecular segmentation of breast cancer. Just to stratify breast cancer in a hormone receptor positive, triple negative, HER2 positive is not enough to reach a personalized cancer treatment. adding new molecular information, stratifying tumor according to specific mutations in the tumor genome may help in having a more comprehensive picture of the heterogeneity of breast cancer, which would help us in fine-tuning personalization of the treatments. What are the premises for a personalized cancer medicine? Well, we have to assume that genetic aberration exists in human malignancies and that some of them will actually drive oncogenesis and tumor progression. We have to assume that at least some of them would be potentially druggable and that there will be tolerable and effective compounds to target these specific genetic alterations. Where are we in breast cancer? Well, we already know that somatic genetic aberrations are responsible for approximately 90% of breast cancers, with multiple regions of gene copy gains, for instance, in chromosome 17. There are high-frequency somatic point mutations in breast cancer, in TP53, PI3 kinase, etc. Additionally, there are low-frequency but recurrent point mutations in target genes that we know already druggable genes. And then there are additional high-frequency mutations. And the list of the significantly mutated genes in breast cancers now includes some 12 or more genes with a different prevalence, but that may allow us to dissect heterogeneity breast cancer in order to do what? Well, in order to have an instrument, to have a means, which is molecular screening, in order to identify for candidate patients for neoadjuvant therapy what would be the best therapeutic scenario, the best therapeutic approach according to the detected mutations in the genome of these tumors. So we can foresee that currently and in the next future, we will use molecular screening to select candidate patients for targeted treatment according to the specific gene mutations. So my epilogue is that pathologists have a central role in optimizing the neoadjuvant treatment of patients with breast cancer, and the evaluation of pretreatment core biopsies must include, number one, the confirmation of invasive tumor, and it may be difficult. The accurate assessment of tumor type and grade, of estrogen, progesterone receptor, Ki67, and HER2 status, and whenever this is feasible for the local resources, to be proactive in all those studies and investigations based on molecular screening to inform specific treatments in the neoadjuvant setting with new compounds for the benefit of the breast cancer patients. Thank you very much for your kind attention.
Thank you, Professor Vayed, for supporting pathologists that we are